Hello, my name is Dori Kleesis and I'm with Mount Sinai Health System. I'm with Niyam Gandhi, the Executive Vice President and Chief Population Officer of the Mount Sinai Health System in New York. Thank you for joining
Yeah,
us.
thanks for having me, Dori.
So talk about the hospital of the future. Why is the move away from fee-for-service medicine so important?
It's a great question. There's a lot of effort in the industry right now around reducing total cost of care, making sure that healthcare is affordable and sustainable for the population, for everybody across the country. And a lot of the discussion ends up being around political things of who should pay and how should they pay. And really what it gets down to, if we really want to address the root cause, is the incentives are wrong in healthcare. And the incentives were right for 50 years ago when technology was what it was, when the focus of the healthcare industry was really sick care, right? It was treat illness and prevent death. And so if the entire focus is to treat illness and prevent death, then it makes sense to pay for each service that we deliver, fee for service. Well, now we have a lot more tools available to us. We can address healthcare in a different way. We
want to keep people healthy
we
as
want
the
to keep
model.
people healthy. Exactly. We can keep them healthy and out of the hospital. We can help them address their chronic disease before it gets out of control. So it's really treating the whole person and preventing illness. Well, if we want to do that, we need to pay for it differently. And so there's been an increasing move in healthcare to value-based reimbursement, to actually pay for value rather than the number of services. For, are we helping people live healthier lives? Are we reducing costs downstream? And are we improving patient satisfaction while we do it?
Does that take a different care model?
It does, absolutely. And I think a great place to where it manifests is in primary care. So if primary care is fee for service, the physician sees the patient who's in front of them, then they see the next patient, then the next patient, and they get paid for each one. If we're thinking about managing a whole population, keeping them healthy, the primary care physician is kind of a quarterback in charge of a team, thinking about all 2,000 people that they're responsible for. So they actually want to monitor who was in the hospital yesterday, who didn't fill their prescription, who maybe has uncontrolled hypertension that's starting to progress. Bring those people in. It's not about just seeing the patient in front of you. It's about thinking about the patient who's not in front of you.
But how do you do
and
that
getting them in.
efficiently? Through electronic medical records, big data? How does that happen?
So the approach that a lot of organizations, including Mount Sinai, are taking is that we need to assemble data at the population level. So that's the start. The EMR is certainly helpful, the electronic medical record, but we have other data sources as well. We get alerts from our Health Information Exchange. We get data from the payers. We assemble a view of the population that we're responsible for. So at Mount Sinai, we have about 500,000 lives where we're responsible for the total cost of care, total quality, end to end. We pull all that data together and we surface it to the primary care physicians and their teams. To your point about being efficient, then, we also need to think about who does the work. It's not about just the heroic doctor doing it. There are certain things where we want a health coach to engage with the patient. We have data analysts pulling information on the highest risk patients. That's a poor use of the doctor's time to go through a list of 2,000 patients and flag who should be reached out to. We have algorithms for that. We have other types of workers who can do that work. So it's really about building a completely different team that is focused on keeping the population healthy.
Is that team more expensive for the health system, and how do you actually make money? Because a hospital or a system has to make money to pay for the workers.
So the team, I'd say, is about as expensive, the primary care team, maybe a little bit more. But where we make the money then is when we take that responsibility for total cost of care. We get kind of a capitated payment. At the beginning of the year, we're paid so much for the population. And if we're really efficient with the downstream resources, then there's some money left at the end. So our incentives are actually to keep people away from the higher cost things. So with the population that we serve, as an example, last year we reduced inpatient admissions, hospital admissions for that population by about 10%. That's a lot of money, right? Hospitalizations make up 30% of total cost of care. Reducing that by 10%, that's 3% of the cost for the entire population. Well, that pays for the primary care team pretty easily. And then the patients are healthier, they're happier, they're at home more frequently, their disease isn't progressing as rapidly. They can actually get on with what they really want to do. They don't want to think about their chronic disease, they don't want to think about healthcare, They want to live their lives.
But doesn't that also help cut back on people with chronic disease and the cost to the whole entire system if more people?
That's exactly right? So if we take that model and scale it across the entire population, healthcare is now almost 20% of GDP. If we can get even better, right now it's 3, 5, 7% lower total cost of care. What if we get to 10, 20, 30, and we scale that across the entire industry? Well, suddenly we've actually saved money for the economy that is no longer spent on healthcare and can actually be deployed to other things.
In the future, do you expect having more patients under this care model at Mount Sinai?
Yeah, we're now at a point where we've contracted in this model with pretty much all of our payers, but we're continuing to expand our network. We have about 700 primary care physicians that work with us on population health. I think by the end of the year, it'll be closer to 800. Within 3 or 4 years, we'll be over 1,000 of those physicians. So we'll be closer to 1 million lives at that point in time. And then, others are doing this as well. And so hopefully we'll get to a point where the majority of the population in our market is receiving care in this sort of model.
Well, thank you very much. You're changing the model of care at Mount Sinai and throughout the country as a model, hopefully. So thank you so much.
Thank you.